Welcome everyone to this short Aspen program, Enteral Nutrition with COVID-19, Managing the Acute Respiratory Distress Syndrome Patient in the Prone Position. My name is Michelle Kazanecki, and I'm the lead clinical dietitian at Froedtert Hospital in Milwaukee, Wisconsin. I'll be presenting these slides today along with Emily Nicolai, clinical dietitian at UNC Medical Center in Chapel Hill, North Carolina. To start with a little background on this topic, coronavirus disease 2019, or COVID-19, is caused by the Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2, infection. Hospitalized patients with COVID-19 often present with respiratory symptoms and develop ARDS. About 14% of these patients require ICU-level care, and 12% require intubation and placement on a ventilator. To reduce the likelihood of intubation, it's important to maintain adequate oxygenation, which may be achieved by placing patients in the prone position. Proning is the process of turning a patient with precise, safe motions from their back onto their stomach so that they're lying face down. An example of what this looks like is shown here. Intubated and ventilated patients will be placed in the prone position by medical staff, whereas non-intubated patients may be encouraged to voluntarily or self-prone. When a patient is in the prone position, the pressure and volume delivered from ventilation is more evenly distributed, which allows the lungs to expand, collapsed alveoli to reopen, and secretions to drain better. This results in improved oxygenation in up to 70% of ARDS patients. Not surprisingly, proning has also shown to improve mortality rates in patients with severe ARDS. The nutritional assessment for this population is very similar to any other patient admitted with pulmonary compromise. The respiratory failure experienced with COVID-19 is similar in nature to ARDS, and therefore has similar nutrition implications and considerations. For example, ARDS is characterized by inflammation that results in worsening ventilation and high oxygen demands. Increased work of breathing results in fatigue, and oxygen desaturation while eating results in poor oral intake. Inflammation also contributes to anorexia and loss of lean body mass. While patients with COVID-19 experience these same symptoms, they often present with persistently high fevers, gastrointestinal symptoms such as diarrhea, nausea, vomiting, and abdominal discomfort, and frequently report poor oral intake for days to weeks prior to admission. COVID-19-related ARDS is also characterized by a prolonged hypermetabolic, hypercatabolic, and hyperinflammatory state, which has a significant and deleterious effect on nutrition and metabolism. Before discussing nutrition management for patients with ARDS while in the prone position, I'll briefly review this enteral nutrition care pathway, which is applicable to all critically ill patients. These steps include assessment of the patient, including EN appropriateness and enteral access, recommending and prescribing the EN regimen, reviewing the order, preparing and labeling the formula, administering the EN, monitoring and reevaluating the patient, and discharge planning for transitions of care. Additional resources can be found on Aspen's website. Given the lack of direct evidence in patients with COVID-19, many of these recommendations are based on indirect evidence from critically ill patients with sepsis and ARDS. Early initiation of enteral nutrition is recommended for patients who are unable to consume an oral diet. This means starting EN within 24 to 36 hours of ICU admission or within 12 hours of intubation. Early EN, compared with delayed EN or withholding EN, has shown improved mortality and reduced infections. In patients with sepsis and shock, EN can be safely provided in the absence of escalating vasopressor doses and symptoms of gastric ileus. For enteral access, nasogastric or orogastric tubes can usually be inserted at the time of intubation. An abdominal X-ray should be done to confirm that the tip of the feeding tube is in the stomach prior to initiating EN. When patients undergo proning, it's important to ensure that the position of the feeding tube is safely maintained. If there is concern about tube displacement during turning, hold EN and repeat abdominal imaging. While institutional practices may differ, a post-pyloric tube may be placed if efforts to maximize gastric feeding tolerance have failed, although you may need to avoid post-pyloric feedings in patients who are hemodynamically unstable and requiring vasopressors or paralytics. Additional considerations for the COVID-19 patient revolve around exposure and the risk of staph contamination. Enteral tube placement is an aerosolizing procedure, and placement of postpyloric tubes may require additional time compared to gastric placement. PPE is also required for these procedures. Use of a standard isotonic formula is recommended when initiating EN, although peptide-based formulas may be considered in the setting of impaired gastrointestinal function. Continuous feeding is also recommended, as this has been associated with decreased aspiration risk, and the continuous nature of nutrient provision optimizes blood glucose control. An initial rate of 10 to 20 mL per hour is recommended, with slow advancement to 80% of goal by the end of the first week. Patients in the prone position can generally tolerate EN infusion rates similar to the patient in the supine position.
Thank you, Michelle. As a group, mechanically vented patients undergoing pronation are at significant risk for impaired gastric motility for several possible reasons, including the need for opioid use for sedation, vasopressor requirements, flat bed positioning, and high abdominal pressure. And we are noticing that mechanically vented COVID-19 patients are experiencing greater need for and longer requirements of narcotics, sedatives, and possibly paralytics compared to non-COVID patients. Therefore, they are at even greater risk for poor gastric motility and delayed gastric emptying than their non-COVID counterparts. COVID patients are also demonstrating rapidly changing and wide-ranging pressor requirements. While the threshold for holding enteral nutrition with worsening hemodynamics is not well defined, trophic or no feeds should be considered for patients who require escalating or multiple vasopressors. Lastly, the nature of the prone position increases abdominal pressure, which in itself may exacerbate feeding challenges. Evidence of persistent GI intolerance that may warrant holding enteral nutrition includes symptoms such as vomiting, a distended, firm, or tense abdomen on exam, and radiographs concerning for ileus or obstruction. While abdominal exams and imaging may be difficult while the patient is prone, clinical findings such as vomiting, concern for constipation, especially if the patient is on narcotics, worsening hemodynamics with escalating pressor requirements, potentially MAPS below target range, and a rising lactate, may be suggestive of poor GI motility and hypoperfusion, and trophic or holding of enteral nutrition may be appropriate. And we'll note that the monitoring of gastric residual volumes as a method to assess aspiration risk or degree of gastric emptying is no longer considered accurate or reliable. However, if your institutional protocol includes residual checks, only hold enteral nutrition if residuals are greater than 500 milliliters and there is persistent evidence of GI intolerance. Early consideration and initiation of promotility agents is suggested for this population, and parenteral nutrition may be warranted should GI issues and feeding intolerance persist. As Michelle mentioned, most prone patients can be gastrically fed, so clinicians should aim to start and advance feeds for the prone patient as they would for the supine patient, while being mindful of the potential factors that may increase the prone patient's risk for feeding intolerance. And feeding in the prone position is safe. No increased risk of pulmonary complications with feeding prone have been noted. Implementing practices that will maximize a patient's tolerance to enteral nutrition, such as maintaining reverse Trendelenburg positioning to at least 10 to 25 degrees with feeding, as shown in this picture, and following strict aspiration precautions with routine oral care, are also important. And while there is no direct evidence supporting holding enteral nutrition before and after turning the patient as an attempt to minimize aspiration risk, some institutions do it. If your facility follows this practice, it is important to account for time off of feeds to prevent underfeeding and to also consider other medical therapies which may be significantly impacted by essentially a short-term MPO status, such as insulin regimens and the risk of hypoglycemia. A colleague and I created this flowchart as a resource for nurses and providers to guide their assessment and strengthen their decision-making capacity when enterally feeding the ICU patient, with decision points included for the prone patient. At our institution, copies are distributed throughout our medical ICU, as well as placed in patient rooms, so they are most readily available for providers to use in the moment when such decisions are made. Not every patient will easily fit within the framework of this flowchart, but it's likely appropriate for most patients. It's important to note as well that while this is applicable to the COVID patient, it is not COVID specific. A word on the self-proning patient. Patients may be encouraged to self-prone to try to improve oxygenation and prevent intubation, but the prone position itself may be a barrier to adequate oral intake. So liquid supplements and calories may be easier to consume than a solid meal, and patients may need frequent reminding and encouragement to eat and drink. It may be helpful to keep food and drinks easily accessible and at the bedside. And for the patient experiencing nausea, constipation, considering antiemetic or promotility agents early to help symptom management may be helpful. A daily multivitamin with minerals is recommended for patients with poor intake, as in the non-COVID population, and we should consider nasogastric feeding tube placement if the patient cannot meet their nutrition needs orally with the above efforts. Ensuring successful implementation and practice of feeding the prone ICU COVID patient extends beyond direct patient care. So it's important first to define what your institutional needs are, especially if proning is an unfamiliar practice at your hospital. A few examples are listed here. At our institution, it was identified early on that a proning order set was necessary in the electronic health record that could be selected when placing enteral nutrition orders. You could consider whether policy updates or revisions are warranted. Ask staff, including nurses, physicians, and dietitians, if educational resources or in-service opportunities would be helpful. And it's incredibly important to communicate. This is vital, as with any new practice, however, even more important and perhaps challenging in this new virtual world that COVID has created. It has in fact been a motivating factor driving the development of this project. So be creative in your communication efforts and be available for questions. Think of ways to help education and information sharing be simple and convenient for staff, and make sure they can easily get in touch with you for questions. Creation of tip sheets, algorithms, and FAQ documents have been very successful in our institution. The key points Michelle and I would like to convey to you from this presentation are that most prone patients can be gastrically fed similar to supine patients. We should initiate continuous feedings early using a standard high-protein isotonic formula and advance to goal as tolerated. Implement strict aspiration precautions and maintain reverse Trendelenburg positioning with feeding while prone. And COVID-specific considerations include minimizing procedures that may increase provider exposure risk, such as post-pyloric tube placement, and recognizing that these patients may be at greater risk for GI dysmotility depending on their degree of critical illness. Early addition of promotility agents, aggressive bowel medication regimens, and consideration of parenteral nutrition may be warranted. And lastly, strong communication and identification of institutional needs will lead to safe and successful nutrition management. We hope that this information serves as a practical resource for dietitians and all providers caring for ICU COVID patients who undergo pronation, and that it helps support, strengthen, and encourage our goal of providing safe and effective nutrition therapy in the ICU setting. Thank you. A list of references are included here. This educational offering was provided to you by Aspen. Financial support was provided through an educational grant from Nestlé Health Science.